This conference will now be recorded.
All right, so we're going to cover chapter 24, psychiatric emergencies. So in all reality, there's not a lot of a difference from the EMT level to the AEMT level as far as psych emergencies go. The big change would be paramedic level when we have different chemical restraint that we can utilize. But at the AEMT and EMT, a lot of it's pretty much the same. There's not a big change with that. All right. All right. Let's see. There we go. So we're going to cover our standard competencies with medicine, and then the psychiatric recognition and behaviors that pose a risk to the provider as well. All right. So a psychological or behavioral crisis might be the result of a medical condition, medical illness, mind-altering substance, or stress. So really, it's our job as clinicians to come up with a differential diagnosis. Yes, we need to diagnose these patients as well, to find out what potentially could be going wrong by doing different testing, if we are allowed to do it. So what I mean by that is, will the patient allow us to touch them in a way that we can do an assessment? That's where it becomes a tricky topic to be able to convince that to work. So the myth and the reality. So perfectly healthy people may have some symptoms or signs of mental illness from time to time. It happens. Or we're stressed out, depressed, something may happen altering our life, things may change. So a common misconception about mental illness is that you are feeling bad or depressed. So you must be sick. It has to be sick. There's definitely something wrong with you. But reasons for feeling depressed: divorce, loss of a job, death of a relative or friend, someone really close to you passes away. It doesn't make you sick. You're sad. It's okay. It happens. It's part of life, right? So sadness is a normal reaction to a crisis situation. So if sadness becomes long term, then it may be an indication of a behavioral problem. Short term is okay. We're allowed to be sad. Many people believe that all individuals with mental health disorders are dangerous, violent, or otherwise unmanageable. There's only a small percentage of people with mental health problems that fall into these categories. So whereas you cannot determine what has caused a person's behavioral problem, you may be able to predict when a person will become violent. So defining that the behavioral emergency. So behavior is what you can see of a person's response to the environment. So responses can be obvious or unclear on what's going to happen. Most of the time, people respond to the environment in reasonable ways. So at times, stress is so great that the normal ways of adjusting do not work. So a person's behavior is likely to change, even if only on a temporary basis. New behavior may also not be appropriate or normal as well. So we got to pay attention to that when interviewing not just the patient, but talking to bystanders or friends, family, relatives, saying, what's changed over the last 24 hours? What's changed over the last month? Has there been a death in the family? Has there been some kind of crisis event that has happened? So abnormal behavior is anything that deviates from society's norms and expectation. So this tends to interfere with a person's well-being and the ability to function, and may be harmful to an individual or a group. Right? So we want to make sure we look into this and keep our situational awareness active at all times. So a behavioral crisis or emergency is any reaction to the events that interferes with activities of daily living. All right, so ADL it's called. Or has become unacceptable to a patient, family, or community. So for example, if the interruption of the daily routine tends to recur on a regular basis, then the behavior is also considered a mental health problem. It is then a pattern rather than an isolated incident. So isolated being like short-term incidents are normal, But when you start seeing a pattern of a behavior, that's when it starts becoming an actual incident. Or an actual, not incident, I should say that. That pattern makes it an actual problem that needs to be dealt with someone of a higher power of level of training, I should say. So if an abnormal or disturbing pattern of behavior lasts for at least a month, it's a matter of concern for a mental health standpoint. Okay, they need to speak with someone to get this cleared up or medicated, depending on what needs to be done. So if an abnormal or disturbing pattern of behavior lasts for a month, we look at chronic depression as a medical diagnosis or a persistent feeling of sadness, despair, or discouragement. So a person who is no longer able to respond appropriately to the environment may be having a psychological or a psychiatric emergency. So with a patient, it may show signs of agitation or violence or become a threat to themselves or others. So they become a threat like suicidal ideations or homicidal ideations as well. So psychiatric emergencies are more serious than typical behavioral emergencies, as an immediate threat to the person involved or others in the immediate area should be considered a psychiatric emergency. So the magnitude of health problems. So according to the National Institute of Mental Health, at one time or another, nearly 1 in every 5 Americans have some type of mental disorder. So an illness with a psychological or behavioral symptom that may result in impaired function. This can be caused by social, psychological, genetic, physical, chemical, or biological disturbances. So a common cause of behavioral alteration are listed on table 24.1 in your books. So you'll be able to see that table of different behavioral alterations. So let's talk a little bit more about the pathophysiology of this. So factors that can produce behavioral emergencies or abnormal behavior or altered mental status would be like sudden grief, emotional conflicts, psychological problems, or sudden illness. One second. We also will find like recent trauma, drug or alcohol intoxication, diseases of the brain such as like Alzheimer's, dementia, hypoglycemia, hypoxia, and exposure to excessive heat or cold. So a lot of these things we can try to rule out. If it's hypoglycemic, check a blood sugar. Check a pulse oximeter reading. If they're hypoxic, we give them oxygen, right? So there's some things we can do as testing to rule certain things out on our differential diagnosis. So organic causes of behavioral emergencies. So organic brain syndrome is a temporary or permanent dysfunction of the brain that is caused by a disturbance in the physical or physiologic functioning of the brain tissue. Some causes would be like a sudden illness, recent trauma to the head, seizure disorder, drug and alcohol intoxication, overdose or withdrawal, diseases of the brain such as Alzheimer's disease and meningitis. Some other altered level or altered mental status can also arise from low level of blood glucose, so low hypoglycemia, lack of oxygen, adequate blood flow to the brain, so a stroke could cause this as well, excessive heat or cold. So altered mental status may be an indicator of a psychiatric disease such as bipolar disorder or an acute medical illness. So again, this is why we need to have differential diagnosis and look at different looking at the differential diagnosis and utilizing our tools of the trade to help rule things out. So when people are constantly exposed to stressful psychological events or a developmental influence, they may develop abnormal reactions. So a person in crisis has two alternatives for dealing with this threat. One, they can cope with it by finding ways to alter the situation to the individual's perception or um, the different perception of it, that the threat is no longer stressful. An attempt to alleviate, or number two, attempt to alleviate the discomfort by escaping from that stress. Either they can escape and get away, or they can cope with it and kind of deal and find a way to work around it. The sociocultural factors directly affect biology. So, like behavior response as well, excuse me, to the stress of the emergency. So, injuries and illnesses that cause and different causes. Acute illness can cause those abnormal behaviors. So, an acute illness like meningitis, things like that. An acute traumatic situation that creates a great deal of stress, whether someone died in the family, someone that was close to you, whatever it may be. Post-traumatic stress disorder, or PTSD, is a severe form of anxiety that stems from a traumatic experience. And PTSD doesn't have to be just military in nature. It could be anything. And we're seeing a lot of that more now with EMS providers that have been doing this for a long period of time. Even a short period of time can happen too, but just that built up stress. So, like when I first started EMS forever ago, I'm sure that the people in the room, like Matt Harrington, you can probably speak for this as well. We didn't have the availability in the late 90s and whatnot for CISDs and the ability to speak. And if you talked about your calls to anybody, that was shown as a sign of weakness. So we were told to keep it in, deal with it, suck it up. You can't handle this job, and don't stay in it. And that's the environment we grew up in the 80s, 90s, to early 2000s. And finally, people said, "Oh my God, EMS providers and firefighters are killing themselves, day in and day out, for suicidal ideations, thoughts, things like that." But all of a sudden, like, we need to get these people help. So it's hard. It's easier for some to open up that are newly coming into EMS versus ones that have been doing this for a long time that were told if you talked about it, you were considered weak. I was looking at the room and people that have been in this job for a while. I know, Justin, you've been in this job for a while too. Matt Harrington.
Yep, I've lost a lot of good friends.
Yeah, Sean. I didn't see your name on the list, Sean. Sorry, you're buried down the bottom. But yeah, when we first started, though, lost way too many. But we were always told it was a sign of weakness if you discussed it, right? That's what we were always told growing up.
Yeah,
now,
and the only time you ever heard from anybody was on like a mass casualty. That's the only time you got like a stress debriefing, is on a really bad mass casualty. Car accident with 2 or 3 dead bodies in the rug, you didn't hear anything about it.
nope. And I literally the other night here on shift, was it Tuesday night? Tuesday night. We got called for a CPR in progress. We get there, there's a DNR in effect, so we didn't do anything. Elderly woman. Literally, as soon as we cleared, I got a phone call from our dispatch center saying, "Hey, you guys good? You guys okay? I know you guys had a DOA." Yeah, we're fine. This was expected. DNR in effect and everything else. But now we're starting to see more of that. Supervisors, chiefs, officers, fire, private, doesn't matter. We're starting to see more of the, "Hey, are you good? You want to talk about it?" No. And then they check in 24 hours later. "Hey, you good?" Make sure everything's all set. So we never had that back then. And now we're starting to see more of it now. So to kind of throw that in there. So the PTSD, it's real, it's there. Most everybody has it in one way, shape, or form. The question, the big thing is, though, is what's going to trigger the PTSD response, right? And a lot of people understand their triggers, and they try to find ways to cope with it so they can move on and become better people with it and live around it. But stress is definitely there. And substance-related causes, that PTSD can turn people to alcohol, cigarettes, illicit drugs, other substances that may change the way a person feels, behaves, thinks. So a lot of this stuff kind of stems into it as one whole thing. Functional disorders like etiology cannot be traced to an obvious change in the the actual structure or physiology of the brain itself. So examples of mental disorders include schizophrenia, anxiety conditions, and depression. So what I do with my EMT classes, or I've done in the past when I had in-person classes, since we've swapped to virtual, it's been a little bit more difficult. So usually I say it's a homework assignment of some sort. Try it out. Let me know how it worked for you. If you go onto YouTube and you type in schizophrenia, you can literally play that. And what I try to tell my students to do is close your eyes, or hit play first, then close your eyes. Listen to all the voices in your head, because that's what's going on. It's make-believe voices on the YouTube video of what a schizophrenic would hear, and try to think of a grocery list of 10 items that you need while having all these voices in your head calling you a loser and a piece of crap. People that are schizophrenic live with that day in and day out, weeks, months on end, with these voices in their head shutting them down. They're no good. They're worthless. They're useless. See them staring at you, see them just on and on and on. So those are the things that these people have to go deal with on a daily basis, right? And if you guys ever want to try it, literally find it on YouTube, close your eyes, listen to it for a minute, and let's start getting in your head and try developing a grocery list in your head with your eyes closed, and see how difficult that actually can be. All right. So anxiety conditions, depression, these things that people deal with on a day in and day out basis. It's not our place to judge, it's our place to help. Psychiatric signs and symptoms reflect the body's attempts to maintain its balance in the face of physical stress. So grouped according to the systems they affect. With that, the physiological functions involved are conscientious motor activity, speech, thought, affect, memory, orientation, and perception. And this can affect consciousness, motor activity, speech, thinking, mood, and affect, memory, orientation, perception, and intelligence. There's a lot there. This is why we got to make sure that if we come in contact with these patients, we treat them with the utmost respect. We're going to go over how to do a scene assessment and size up here. So obviously, scene safety, BSI, scene size up. Determine MOI or NOI. Situational awareness until you drop the patient off at the hospital, because things can change quickly. Form a general impression. Respect the patient's territory and limit touching without permission. All right, approach slowly and purposefully while avoiding threatening actions, statements, and questions. Right? Be there to listen to them. That's what we are there for. And tailor your assessment to get what you are looking for without being aggressive. So a behavioral crisis puts tremendous stress on one person's coping mechanisms. So the person is incapable of responding reasonably to the demands of the environment. This may be temporary or as an acute illness, or maybe long-lived, such as a complex chronic mental illness. The patient's perception of reality may be compromised or distorted. So we want to limit the number of people around the patient. Watch for signs of agitation and aggression. Look for body language. Read it. Then separate the patient from the bystanders or family members who seem to be exacerbating the patient's condition. Potentially violent patients make up only a very small percentage of those experiencing a behavioral or psychiatric emergency. So assess the level of danger by using history, posture, how the patient is sitting or standing, look at the scene, is the patient holding or near potential lethal objects? And Mike, I'll get you yours in a second. You just put up, I just saw. And what kind of speech is the patient using, like physical activity as well, vocal, physical, the scene, how it all looks. So Mike put down on the message board, word of advice from a therapist. Meet the patient where they are at. Don't be a dick. Don't be judgmental. Statistically, we all have been there before at some point. So can you guys all hear me okay?
Yes.
Nope, not at all, Kevin. You're not coming in loud and clear at all.
Yeah, I can hear you.
All right. Well, so Mike Ball, you said you can't hear me though?
No, you're good, Kevin.
I'm reading Mike's message. He says can't hear a thing. Anybody else?
Oh, no, I got you fine.
All right. So Mike, if you can't, if you need be, Mike, you can always just log off and log back in again, and that might help if you can hear me. All right, next thing we're going to look at here, obviously, is let's consider the following, like poor impulse control, history of truancy, fighting, or uncontrollable temper, low socioeconomic status, unstable family structure, or the inability to keep a steady job. Tattoos, I don't know why tattoos are even listed, but it's one of the things to look for, apparently. Substance abuse, depression, functional disorder, as well. Looking at airway and breathing, circulation, ABCDEs. Appropriate interventions based on your assessment and findings. What do we need to do to help them? Circulation, pulse, rate, rhythm, quality, blood pressure, if you can get it. Evaluate the presence of shock, bleeding, evaluate skin color and temp condition, right? And then transport. Where are we going to transport to? Notify the hospital early that you're coming in with a psychiatric patient so they can plan for it. Now, obviously, bigger hospitals have more space, but your small little critical access hospitals, a lot of them only have one psych room in the emergency department. That's it, one psych room, right? So they may not have the ability to take these patients. And if they do, they may have to clean out rooms or whatever to make it turn it into a psych room as well. So keep that in mind. And they also have to make sure they have security available. And small little hospitals don't have a ton of security. Usually they have one, maybe two people, and that's it. One second. All right. So looking at history taking, we want to make sure we investigate the chief complaint. Focus questions on the immediate problem. Okay. We talk about sample and OPQRST and all that, OPQRSTI. We need to tailor our assessments with psychiatric patients. Right? Get to the point where you need to find out their meds, allergies, things like that, past medical history. But you can also get a lot just by looking at pill bottles. Avoid using threatening actions, statements, questions. If you don't get on the stretcher, we're going to forcefully put you there. How to avoid those from happening? Approach the patient slowly, but purposefully, right? Don't make a fist. Don't look like you're becoming threatening. Evaluate the potential for suicide or harm to others, so SI and HI. Factors increasing the risks include recent depression, recent loss of a family member or friend, financial setback, drug use, or evidence of a detailed plan. Right? A patient who has had detailed plans and access to the means to complete it is likely to carry out a plan. detail. The I'm going to kill myself, that's not a detailed plan. Very nice, Tandra. Very nice. So actively listen. Be supportive, empathetic. Allow time for answers and limit interruptions. Right? Gang questioning is bad. One person, have a conversation, show them that you're there to listen, right? And still try to get your assessment done. Note facial expressions, pulse rate, respirations, tears, sweating, blushing. Look at the eyes of the patient, right? Make eye contact. It shows that you actually care, and you can see what their pupillary size is and see if they're actually medicated or not, or on some type of medication causing this. Utilize the surrounding people, family, friends, observers, things like that. They're great in answering questions. And they might be able to provide some history on that patient as well. So when trying to determine the etiology of the patient's condition, consider 5 major areas as possible contributors. Let me go over those 5 for you. Is the patient's central nervous system functioning properly? Are they on a medication that can inhibit that? Right? What is the general condition of the patient's environment? Is the patient dressed appropriately? Are they clean? Or is their environment clean? Is there any evidence of substance abuse? Are hallucinogens or other drugs or alcohol a factor? Does the patient see strange things? Is everything distorted? Right? Do you smell alcohol in the patient's breath? Number 4, are psychogenic circumstances, excuse me, symptoms or illnesses caused by mental rather than physical factors involved? If the patient has a history of psychiatric illness, has there been a recent change in medication and a recent drug change? So you want to document the patient's intellectual function. Is the patient oriented, memory intact, able to concentrate, appropriate judgment? Does the patient have distorted thoughts, delusions, hallucinations, or unusual worries or fears, or express suicidal or homicidal threats? Note the speech pattern and content as well. Is the speech garbled or, excuse me, so is the speech garbled at all? Is there potential that it could be a stroke? Is there potential that it could be under the influence? What is the patient's mood like? What is the patient's hygiene like? What is the patient's motor activity? Is it normal? You know, are they on methamphetamines? Are they using cocaine? What are they doing? Look at some physical examination as well. Look for signs and symptoms or signs of an organic cause of the patient's behavior. Obtain vital signs. If you can, look for signs of fever, indications of increased intracranial pressure, right? Meningitis, head trauma. Examine the skin temperature and moisture to note any prominent tattoos or scars. Inspect the head for evidence of trauma. Check the pupil size, equality, as well as any reaction to light. Abnormalities may indicate toxic ingestion or an intracranial process as a source of the patient's behavior. Note any unusual odors of the patient's breath, such as poisons, alcohol, or even ketones for diabetic ketoacidosis. While examining the extremities, look for needle track marks, tremors, unilateral weakness or loss of sensation. Looking at vital signs, using monitoring devices as well to measure and assess oxygenation and circulatory status. Then we do our reassessment interventions that we've done. Reassess our interventions. Reassessment is also routinely performed during transport. We want to make sure we monitor our patients. Then give the receiving hospital advance warning as well. We want to maintain safety for your patient and yourself. Place the patient on the stretcher with straps in place, right? If you have a violent patient, we need to make sure that we restrain them appropriately, right? We never restrain a patient on their stomach. Always on their back, usually in like a semi-forward position. One hand is up tied above, the other hand is down towards the bottom, towards the middle of the stretcher, and secure their legs, all right? Or that they can't sit up and hurt you, and they also don't put them in a position of positional asphyxia. Remain with the patient at all times. Please do not leave your patient. Attempt to eliminate or decrease anything that may distress the patient as well, and avoid being judgmental. If there's any reason to suspect the patient may have taken something, bring any medication or drug found at the scene to the medical facility as well. All right. Any questions up to this point? You guys doing okay? Good? Awesome. All right, let's start talking about different things we could run into. So the first one would be acute psychosis. So acute psychosis is a state of delusion in which a person is out of touch with reality. So the line between their reality and fantasy is blurred. Causes of these psychotic episodes would be using mind-altering substances, intense stress, delusional disorders, and schizophrenia. Some episodes last for brief periods, others last a lifetime, like schizophrenia. Disorganization and disorientation are ways in which various conditions such as schizophrenia and organic brain syndromes may present themselves. Schizophrenia is a complex disorder that is not easily defined or easily treated. Typical onset occurs during early adulthood, with symptoms becoming more prominent over time. Some influences thought to contribute to the disorder be brain damage, genetics, neurobiologic influences, physiological and social influences, as well as some of the signs and the symptoms would include delusions, hallucinations, apathy, a flat affect, erratic speech, emotional responses, motor behavior or lack of or excessive motor behavior, and a lack of interest and pleasure. As far as doing an assessment for psychosis, the patients are usually incoherent and rambling in their speech. Although an examination of the patient is rarely possible as well. So again, they may not even let you anywhere near them, but the goal is to get them to the emergency department for further evaluation. The principal objective of the provider is to transport the patient to the hospital in an atraumatic fashion. So we can use something called the COAST map mnemonic. So consciousness, orientation, activity, speech, and thought. The memory, affective mood, and perception. All right. It's getting windy over here. So the management of psychosis, usually methods of reasoning with a patient are unlikely to be effective. So use your uncomfortable feeling to help make a tentative diagnosis. Explain in plain language what is being done and what the patient's role will be. Directions should be simple, consistent, firm, right? No long-winded explanations, short to the point. Keep orienting the patient to time, place, and the people in the environment, right? Let them know who you are, what's going on. Reassure the patient and point out landmarks to help orientate the patient as well. Non-pharmacologic techniques should be adopted, okay? So no meds. Consider paramedic backup for the administration of sedatives, though, or anti-anxiety drugs if the patient is not compliant and possibly represents a danger to self or others. So we don't want to have to use chemical restraint as paramedics, but if we need to, they're available in there. So suicide is depression is the most significant factor that contributes to suicide. Anytime you encounter a patient experiencing depression, consider the possibility of suicidal ideations. Risk factors for suicide are listed in Table 24.5 in your books. So it is common misconception that people who threaten suicide never commit it. Suicide threat or an attempt is a cry for help. Threatening suicide is an indication that someone is in a crisis that they can no longer handle. So they are reaching out. Please do not miss those signs, okay? People have problems. It happens. So if they're at that point, they're looking for help, help them. All right. Warning signs. Does the patient have an air of tearfulness, sadness, deep despair, or hopelessness that suggests depression? Does the patient avoid eye contact, speak slowly, and project a sensory of vacancy? Does the patient seem unable to talk about the future? Ask about the patient about vacation plans. Is there any suggestion of suicide? Does the patient have any specific plans relating to death? Additional factors for suicide would be unsafe objects in the patient's hands or nearby, unsafe environment, evidence of self-destructive behavior, imminent threat to the patient or others, underlying medical problems, or a suicidal patient that may be homicidal as well, wanting to kill other people. All right, so agitated delirium is a condition of impairment in cognitive function that can present with disorientation, hallucinations, or delusions. So agitation is characterized by restlessness or irregular physical activity. So although the patients experiencing delirium are generally not dangerous, if they exhibit agitated behavior, they may strike out irrationally. So just be aware of that, be aware of that surrounding. Symptoms may also include hyperactive, irrational behavior with inattentiveness to vivid hallucinations. Right? So I literally had a patient one time that called 911 because he went home and saw multiple people stabbed in his apartment. Right? So I get on scene and do an assessment, and there's nobody there. This kid was hallucinating, vivid hallucinations. And he actually literally walked up to the couch where he saw the bodies and said, "This is someone right here. Aren't you going to help them?" It was his cushion on his couch that he thought was a real person. Right? So he ended up being transported for vivid hallucinations. Right? Remember that hallucinations are erroneous perceptions of reality. So the patient may see you as a threat as well, even though you're not. If you think you can safely approach the patient, be calm, supportive, empathetic. Let them know who you are and why you are there. Right? Limit any physical contact and do not leave the patient unattended unless the situation becomes unsafe. With mood disorders, among the most prevalent mental disorders, up to 21% of the U.S. population will experience a mood disorder or major depression at some point in their lives. The changes in effect are accompanied by other symptoms, which cause major disturbances in the person's ability to function. Patients who experience either depression or mania, or they're manic, have a unipolar mood disorder. Patients who are alternative between manic and depression have a bipolar mood disorder. Manic behavior is one of the most striking psychiatric conditions, where abnormally they could be very happy, joy, with hyperactivity and insomnia. Patients are also awake and alert, but are easily distracted. They have marked hyperactive and unable to concentrate. Flight of ideas and delusions as well. Racing thoughts. The memory may also be distorted by underlying delusions, psychotic symptoms such as hallucinations, high probability of getting themselves into trouble or one sort of another. With depression, more than 7% of U.S. adults, which is 17.3 million, experienced at least one major depressive episode in 2017, based on numbers. It affects women more frequently than men and may occur at any age. Identified as sad expression, bouts of crying, and listless or apathetic behavior. This may also occur in episodes with a sudden onset and limited duration. So signs and symptoms of depression for more days than not for a period of at least 2 years may be chronic form of depression known as maybe a chronic form of depression or a disorder. So a diagnostic feature using the mnemonic gas pipes would be guilt, appetite is normal, sleep disturbance usually takes the form of insomnia, paying attention, impaired ability to concentrate, interest, loss of interest in things that were once important, psychomotor abnormalities can be increased, form of agitation or slowed from agitation, energy, no energy at all, and suicidal thoughts. So gas pipes is one you can utilize. So neurotic disorders, or a collection of mental disorders without psychotic symptoms and lacking in the intense psychopathology of other mood disorders. Treatments come at a substantial price, though, with these. Anxiety disorders are mental disorders in which dominant moods and fear of apprehension. So generalized anxiety disorder. So if a person worries about everything for no particular reason, or if that worrying is unproduced or unproductive, I should say, by the person, and the person cannot decide what to do about an upcoming situation. They may be experiencing what they call generalized anxiety disorder, or GAD. So patients are often treated with pharmacologic agents in counseling. Phobias involve an unreasonable fear, apprehension, or a dread of a specific situation or thing. So when confronted with a feared object or situation, the person with a phobia experiences intolerable anxiety, right? So explain each step of treatment in detail before you carry it out. What kind of signs and symptoms would you guys experience or expect to see in a patient who has a phobia and has the intolerable anxiety? What kind of signs and symptoms would you potentially see? I see Matt put down irritability. I got to have more class participation here. What else would you might see? Okay, anxiousness, yeah, anxiety. What else? Hyperventilation. What does hyperventilation do? You can unmute and talk too. It's okay. No one's going to bite. Yeah, altered mental status due to lack of what? Yeah, not sleeping. So hyperventilation causes a decrease in what? So thinking like ALS providers. Hyperventilation I don't know if someone's typing, but we need to start unmuting and start doing some talking here. Right. So Rosa, decrease in oxygen, decrease in perfusion can cause hallucinations, right? So if we're hyperventilating, what is our end tidal going to do? Be higher or lower?
Lower.
Lower. Okay. So our end tidal is going to drop. There, we're not perfusing anymore, right? And if we're not perfusing, we're not getting enough oxygen, and we can start developing what happened with the chest, with the heart, chest pain, right? So again, you have patients that have phobias, and all of a sudden they become very anxious. Next thing you know, they're causing themselves to have chest pain. So then some people will start saying, well, maybe we need to go down the chest pain route, carpopedal spasms, exactly, right? And they start getting nitrates and aspirin, and they're going down this ACS thing, when really it's not ACS at all. It's anxiety buildup, right? So I want you guys to think about that, all right? Do your assessment. Does this patient really fit that criteria, right? So now at the advanced EMT level, we have 12 leads. So do an EKG on them, right? If it looks like a sinus rhythm, there's no changes in that whatsoever. Just because they have chest pain, do we need to go down that route? And if you have any question, who can you call?
Medical control.
Exactly, 100% med control. Have that consultation with them, right? Transmit that EKG. Have them look at it if you have that ability to do so, right? If you have a smaller hospital and you know the physicians that are in there or the nursing staff, take a picture of your EKG and text it to them, and they can show the physician, right? We have abilities to get information to the hospital to have great consultation to find out if we should go down a certain route, right? Don't get tunnel vision. Look at the big picture that's going on, right? So some medical legal considerations. The medical and legal considerations are more complicated with patients undergoing a behavioral crisis or psychiatric emergency. Did you guys know that when you put a patient into a room in the ER that's psych, the psych rooms, that they cannot lock that door? The door has to remain open unless they have a physician's order to close it. That's everywhere. A doctor has to sign off as an order to close a door because you're taking away the patient's rights. Right? They have the right to have that door open. And if they're voluntary, they have the right to walk out and leave. Right? So legal problems are reduced when the patient consents to care. If they don't consent and we deem that we have taken away their mental capacity to make decisions, right? That can cause a lot of legal issues if you don't document appropriately, right? So gaining the patient's confidence is crucial to allow them to let you go in and actually do an assessment. Mental incapacity can take many forms: unresponsiveness as a result of hypoxia, drugs, or hypoglycemia, temporary but severe stress, depression. All these things can have mental incapacity. So once you have determined that the patient has impaired mental capacity, you must decide whether the patient requires immediate emergency medical care or not. So is the patient in a mentally unstable condition that may resist your attempt to provide care? Never leave the patient alone. Request law enforcement is there if the patient persists treatment or threatens AEMTs or others. Right? Law enforcement can help you. They also have the power to put people in protective custody. We don't have that. All right. We have the ability to transport a patient. We have the ability to deem them not mentally capable to make decisions, but you have to do an assessment to do that. Right? And gaining consent, implied consent is assumed when the patient
Question.
was that?
I got a question.
Yeah,
So, this is like Mass versus New Hampshire, so to speak. So obviously, when we get psych patients, typically in Mass we get everybody. More so, we get at least PD. In New Hampshire, how does that work? Because PD is not usually readily available, right?
correct. It depends on where you are. Some may take an hour. Some could be there in minutes, right? So here's the difference between Mass and New Hampshire. This is actually interesting that you brought that up. So Massachusetts has Section 12, right?
Yeah.
Okay. New Hampshire has what they call a prayer and complaint form. In Maine, it's called blue paper. All very similar. A parent complaint can be filled out by anybody. A Section 12 cannot. That has to be done through law enforcement, right, or a physician.
Yeah.
So if you and I met, let's say I heard you make a threat, I could literally go to the hospital or have PD, and I could fill out a parent complaint form and have you evaluated. Right? Maine has something called the blue paper. So the blue paper in Maine is a court-ordered form that PD can get and the hospitals can get as well that makes it so you have to be evaluated. What does Mass also have though? That law enforcement can enforce. You remember?
No.
Called the Section 9A. Section 9A means PD can force anybody they want to force to go to the hospital, whether they're competent or not. They can say, we're going to put a Section 9A on somebody. Very interesting, right? So if PD saw you walking down the streets of Wakefield, Matt, and they felt something was off, they could Section 9A you and send you to the hospital by ambulance. When you get there, when you get to the hospital, then you have the right to get up and walk away.
Oh, hell no. That's vacation time.
Right, exactly. Oh, it's called a slippery sock vacation. A slip sock, whatever it's called. Right? So again, you have that ability, they have those abilities. So every state's a little bit different. So when you get your advanced EMT licenses, understand your local protocols and what they can do, because there's a lot of different things that are there. So in a situation that is not immediately life-threatening, emergency medical care or transportation may be delayed until the proper consent is obtained. Right? We've seen that with parent complaints. We've seen that with blue papers. We've seen that with Section 12s, where we sit on scene and wait and wait and wait until that section comes in. Next thing you know, the Massachusetts cops are carrying this kid out and tossing him on your stretcher, right? So contact medical control or follow local protocols when in doubt, and consent does matter.
Okay, so here's my question for all you New Hampshire EMTs. If you get a patient that's having a psychiatric episode, do you guys have to request PD and wait for them, or do you guys actually just go in there and risk it?
Anybody else wants to answer or not? But we don't go in and risk anything. So if it comes in as a potential issue of psychiatric or where EMS could be harmed, we're told to stay for PD. So we actually stay for PD until PD arrives, right? And any kind of unintentional or intentional GSW, you sit, you wait. I
Okay.
sat on scene one time for an hour staging for someone who shot themselves because PD is coming from an hour and a half away. And I had to wait until they cleared the scene. The guy blew his hand off cleaning his gun. Accidental, completely accidental. But because it was a GSW, we had to wait, and it took law enforcement an hour and 15 minutes to get to the scene. I sat there bleeding out of his hand, blew his hand right off, his palm. So kind of add that into perspective. Sometimes we have to wait. All right, so as far as restraints go, right, must be ordered by a physician, court order, or law enforcement officer, right? For us in New Hampshire, it's standing order, right? We don't have to get med control or anything else. Now, if you're doing an interfacility transport, then you have to have orders for the restraint. But 911, it's standing order. If you restrain a person without authority in a non-emergency setting, you are exposing yourself to possible lawsuit and a potential danger. If they are a danger to themselves, then we have the ability to restrain. Because that way there, we have pulled all their privileges away. But legal actions against you could involve charges of assault, battery, false imprisonment, and violation of their civil rights. So we use restraints to only protect yourselves or others from bodily harm, not the patient, ourselves and others. If we're going to restrain somebody, law enforcement is present, they are there, and in subduing a disturbed patient, use minimum force necessary to take someone down and restrain them, right? And also have a document witness in attendance as well. So PTSD can occur after exposure to injury to or injury from a traumatic event. It doesn't have to be an actual injury, but it could be exposure to something, right? It could cause PTSD to happen. Signs and symptoms of feeling of helplessness, anxiety, anger, fear, nervousness, nervous system arousal, things like that. So it's estimated that 7 to 8% of general population will experience signs of PTSD at some point in their lives. Heart rate increases, pupils dilate, systolic blood pressure increases, senses are now sharpened, and the mental acuity is heightened. So people with PTSD can relive traumatic events through intrusive thoughts, nightmares, and even flashbacks. Right. So guilt, shame, paranoia, hostility, depression, all these things do exist with PTSD as well. So be aware. And then also think about returning combat vets. Remember where they've been, and now they're coming back to normal civilian life. Right? They have a higher incidence of TBI, sustained from trauma secondary to explosions. TBIs may go undiagnosed because of its manifestations and similar to the symptoms of PTSD, or because the patient downplays the symptoms itself. Right? Try to eliminate excess noise. Right? Do not touch or do anything to a vet without an explanation. Right? Diesel fumes can also be a trigger for combat vets. Take time to establish the history of the patient and listen to the patient's concerns. Be careful in how you phrase your questions. All right. All right. Any questions at all with that?
No, I'm good.
Nope. I'm good. All right. Let's take 10 minutes. We'll come back and we'll get moving from there.
This conference will now be recorded.
So, in all reality, with gynecologic emergencies, nothing has changed since your EMT class. The only difference is intervention. So, IV therapy, fluids as needed, and cardiac monitoring, which is not part of the national scope, but part of New Hampshire scope of practice. So really, there's not a lot of a difference. So with this. So let's get to the introduction. So girls and women in their childbearing years may have major gynecologic problems, excessive bleeding, vaginal discharge, sexually transmitted infections, STDs, and soft tissue injuries. Okay, so some things to think about when we're doing our assessments. Now, when we're doing our assessments on females, we got to make sure we keep them covered, keep their dignity intact, right? Make sure we're doing things on a professional basis. It is a female present provider that have them do the female assessments on them, especially when it has to do with the gynecological issue. And but unfortunately, a lot of times we run double male crews, and we have to still treat. We cannot just not treat somebody because they're a woman. So we have to make sure we do the job. So we'll go over some AMP review. I do apologize. I'm starting to lose my voice again. A lot of teaching today. So AMP review. So the female reproductive organs include the external female genitalia, uterus, vagina, fallopian tubes, ovaries, and the perineum as well. The ovaries, which are an almond-shaped bodies that lie on each side of the pelvic cavity. right? Good for us to understand where the ovaries are located, right? Reason being is ovarian cysts, things like that, can produce here. They are very, very painful and can be causing significant infection if the cyst would ever break, right? So something to think about. Um, so estrogen, progesterone, this is what the ovaries produce, and the ova as well, and hormones secreted by the corpus luteum and a small yellow endocrine structure that develops within a ruptured ovarian follicle or sac, which there's a picture on here. Kind of hard to see though. I see have the front and side view. And switch, there's a picture of that, and I don't have that here. I do apologize. Why are you not changing? There we go. All right. So the other parts will be the fallopian tubes, which extend from the uterus and terminate near the ovary on each side. They carry the ovum and the ovary to the uterus, and they carry spermatozoa from the uterus toward the ovary. I have a back one here, though. Let's redo it. All right, so we look at our fallopian tubes, which run here, okay? This is one of the most common locations for an ectopic pregnancy. So one of the things we got to keep in mind of, any female in childbearing years, okay, and that could be a 13-year-old, right, with unexplained abdominal pain that is currently sexually active, whether they're on birth control or not, okay, unexplained abdominal pain, but has a high chance of being an ectopic pregnancy. Okay, so keep that kind of stuff in mind when you're doing your assessments. The uterus, which is a muscular organ where the fertilized egg implants and grows, is responsible for contractions during labor and helps push the infant through the birth canal, made up of the fundus body, uterine cavity, endometrium, and myometrium as well. Right? The vagina, which is the outermost cavity of the woman's reproductive system, forms the lower part of the birth canal, which begins at the cervix and ends at the external opening of the body. The cervical canal is a passageway from the uterus to opening into the vagina itself. Right? As you can see here, the external female genitalia in the photo. So you have the mons pubis. I'm not sure if that's located on there. The labia majora, labia minora, clitoris. Right, you got the vestibule as well as the opening of the urethra, the vaginal orifice, the hymen, perineum, and the anus. So as you can see looking at the photo. So each month, level of hormones increase in the female and characteristic changes start taking place. They stimulate development of eggs in the ovaries. The endometrium thickens in preparation for a fertilized egg. If the egg is fertilized and implants in the uterus, right, this is where it's suspended until pregnancy ends. If no fertilized egg implants, menstruation begins. The menstruation or the cycle, or cilic shredding of the uterine lining that occurs approximately every 28 days. Lasts 4 to 6 days with blood loss at approximately 25 to 60 mLs. Right? So when we're doing our assessments and we have unexplained abdominal pain or potential of being pregnant, one of the questions you do want to ask is, when was your last menstrual cycle? How long has it been? Now, they could be on a birth control or an IUD in place that make it so they don't have menstrual cycles at all. So again, more questioning you need to ask, and we'll get more into the questioning here in a little bit. So PMS, obviously premenstrual syndrome, are symptoms that occur 7 to 14 days before onset of menstrual flow. It subsides once the flow begins and affects approximately 20 to 30% of all premenopausal women. So stress, diet, alcohol consumption, and prescription or non-prescription drug use may exacerbate PMS symptoms. Right? Women may experience reactive hypoglycemia, resulting in increased fatigue. Pre-hospital treatment is supportive and may administer oral IV glucose if needed. So we still want to make sure we're checking your blood sugar as well. Right? So abdominal pain and cramping in the 2 weeks before the beginning of the menstrual period starts, resulting in ovulatory process. This may start. Hold on a second. I got something in my eye. All right. This may start anytime during ovulation. So signs and symptoms are sharp cramping pain in the lower abdomen, often localized to one side. The pain can often be relieved by over-the-counter medications like analgesics, and persistent pain or any abnormal symptoms are cause for concern. Anything that's different, okay? So we want to make sure we're taking note and asking the question, what's different now than normal, okay? So amenorrhea, let's turn the show back on. All right, is the absence or cessation of that menstrual cycle, menses. Most common cause is pregnancy. But again, IUDs in place will also make that stop as well. So exercise-induced amenorrhea is common in female athletes as well, and may occur when a woman's body fat drops below a certain percentage. Caused by also emotional problems or extreme stress. In adolescents or young adults, may be caused by eating disorders such as anorexia or bulimia. So a bit about pathophysiology. Disorders in the female reproductive system can lead to gynecologic emergencies like acute or chronic infection, hemorrhage, rupture of a cyst, or rupture of the ectopic pregnancy. So PID or pelvic inflammatory disease, very, very painful. Usually require, and also it's a significant infection as well. May require pain management. So acute or chronic infection of the upper female reproductive organs may expand into the fallopian tubes and the ovaries. So the chief complaint or symptoms are pelvic pain, like severe pelvic pain and fever. And some complications would be sepsis, abscess formation, or generalized peritonitis, or infertility. So scarring may cause tubal infertility and increased risk of ectopic pregnancy as well. So patients that have, or females that have PID need to be treated aggressively, especially in the emergency departments with antibiotics. And we also need to look for signs of sepsis as well. So please do not write these patients off and just transport them BLS, right? Pain management. These patients need to reduce the pain levels. It's very, very painful in the pelvic region. So STDs, or what they call now STIs, or sexually transmitted infection. PID is usually typically a secondary infection, with the primary being an STD or STI. Usually it's like often chlamydia or gonorrhea that would cause this and turn into PID. So the treatment involves placing the patient on a position of comfort, providing supportive care. Bacterial vaginosis is most common vaginal infection in women ages 15 to 44, where normal bacteria in the vagina are replaced by an overgrowth of other bacterial forms. Symptoms would include itching, burning, or pain, and may be accompanied by a fishy, foul-smelling discharge. If untreated during pregnancy, this can lead to premature birth or low birth weight, PID, and patients susceptible to more serious infections. Right? This is treated with antibiotics. So a little bit more about the chlamydia as well. Currently the most commonly reported STI in the United States. Symptoms are usually mild or absent symptoms and may cause lower abdominal pain, lower back pain, nausea, fever, pain during intercourse, or bleeding between menstrual periods. And this can lead to PID as well. Okay. So cankeroid caused by infection by the bacterium. I'm not going to try to pronounce that. I'll just probably completely butcher it, but it's there. Which is highly contagious yet curable. Caused by painful sores, ulcers, usually of the genitals as well. May cause swollen, painful lymph glands in the groin area as well with this. So other STIs that are there. So CMV is another one, or a member of the herpes virus family, which is a common viral infection that has no cure, no known cure at this time. They remain dominant in the body for years and can cause prolonged high fever, chills, headache, malaise, extreme fatigue, and an enlarged spleen. People at risk for active infections and serious complications would be those with immune disorders, chemotherapy patients, pregnant women, and newborns who acquire CMV are susceptible to lung conditions, blood conditions, liver conditions, swollen glands, rash, and poor weight gain. Genital herpes is an infection of the genitals, buttocks, and anal area caused by herpes simplex virus type 1 or type 2. Type 1 is the most common, which infects the mouth or lips, causing cold sores or fever blisters. May also produce sores on the genitals, which would be type 2, which is more serious. This can also affect the mouth as well. Primary cause of genital herpes would be more prevalent in women. It's also an active infection where symptoms generally appear within 2 weeks of the primary infection and can last for several weeks. Symptoms would be tingling and sores near the area where the virus entered the body. So with that being said, fever, muscle aches, pains, headache, dysuria, vaginal discharge, or some other symptoms you may come in contact with, or swollen glands in the groin area. So Neisseria gonorrhea or gonorrhea affects the cervix, uterus, and fallopian tubes in women. And it also affects the urethra in women and men. This can also grow in the mouth, throat, eyes, and anus as well. So symptoms are generally more severe in men, but appear about 2 to 10 days after exposure. Women may be infected for months, but experience no symptoms or mild ones until the infection has spread to other parts of the reproductive system. And that's when they'll start noticing more symptoms. So symptoms would be like dysuria, with associated burning or itching, yellow or bloody vaginal discharge, usually with a foul odor. Oh, what did I just do? Hold on. There we go. Change slides on you. Let's see. Where was I here? Foul odor. Right. And then an occult blood associated with vaginal intercourse. So some serious infections may present with cramping, abdominal pain, nausea, vomiting, and bleeding between periods as well, and indicate that the infection has progressed to PID. So a rectal infection or as well, an infection in the throat. So gonococcal pharyngitis. If not treated, the bacteria may spread to other parts of the body, including the brain as well. Other ones would be like genital warts, also caused by the human papillomavirus. or HPV. Some infected people have no symptoms at all. They can live with it with never having a symptom. Others have multiple growths in the genital areas. HPV is an agent in the cervical, vulvar, or anal cancers as well. In pregnant women, warts may become large enough to impede urination or obstruct the birth canal. And if the
Kevin, I lost audio of you.
This conference will now be recorded.
all right, so caused by the yeast infection or vaginal yeast infection, it's what the Candida albicans fungus. So the normal acidic environment of the vagina keeps yeast from growing, right? So if the vagina becomes less acidic, yeast population may increase, resulting in an infection. Conditions that may alter the acidic balance would be menstruation, contraceptives, oral contraceptives, pregnancy, menstruation, diabetes, antibiotics, some antibiotics, moisture and irritation, stress from lack of sleep, illness or poor diet, immunosuppressive disease such as HIV infection or diabetes, And symptoms would be itching, burning, soreness in the vagina, around the vulva, vulvar swelling, thick white vaginal discharge like a cottage cheese appearance, and then pain during sexual intercourse and the burning on urination. So the ruptured ovarian cyst is a fluid-filled sac attached to the ovary, which contains an enormous amount of fluid, which may need surgical removal. So the internal bleeding is rare, but again, needs surgically removed. But if an ovarian cyst ruptures, then it can become very, very infected in that area and cause significant sepsis as well. Ectopic pregnancy, which the pregnancy develops outside the uterus, most often in the fallopian tube. Is vaginal bleeding may be the only sign for that. Also, significant abdominal pain. The leading cause of maternal death during the first trimester is internal hemorrhage into the abdomen following a rupture of an ectopic pregnancy. So other causes affecting normal pathway of the ovum would be previous surgical adhesions, PID, tubal ligation, and intrauterine device as well. So like an IUD. If not caught in time, the fallopian tube will rupture, which is a life-threatening emergency. So never assume an emergency call for vaginal hemorrhage from normal menstruation, okay? So any vaginal bleeding during the third trimester is a serious emergency. So we have two different things. We have placenta previa and a bronchial placenta. Placenta previa will present with a dark red blood, but significant, and a little bit of pain or painless bleeding would be very mild. It'd be dark red, dark in color, with significant blood loss. A bronchial placenta has a little bit of bleeding, but has significant pain, also be bright red blood. So if you notice the difference, this is where the placenta tears away from the uterine wall, causing significant bleeding, or causing bright red, painful bleeding. Other causes would be onset of labor, ruptured ectopic pregnancies, PID and other infections, trauma, lesions from previous surgeries or disease processes. Traumatic causes would be like a straddle injury, blows to the perineum, blunt force to the lower abdomen from assault or a seatbelt injury, foreign bodies inserted into the vagina, abortion attempts, or soft tissue injuries. Endometriitis is an inflammation or irritation of the endometrium, most likely to occur after having a baby or a miscarriage, most commonly caused by an infection, frequently by an STI, like predominantly gonorrhea or chlamydia. Symptoms would be malaise, fever, high or low grade, constipation, vaginal bleeding or discharge, or both, abdominal distension, lower abdominal or pelvic pain. These are, like I said, are treated with antibiotics. If left untreated, endometriitis may lead to septic shock or cause spontaneous abortion in a pregnant patient. All right, so we got to be able to pick up on this stuff quickly and get them to the hospitals to be treated. Endometriosis is an endometrial tissue that grows outside the uterus. One of the leading causes of infertility in women, with 30 to 50% of infertile women having this condition. Many women do not even realize they have endometriosis. They encounter difficulties trying to get pregnant. Most common complaint is pain, generally localized in the lower back, pelvic, or abdominal regions. Symptoms would be painful intercourse, gastrointestinal pain, dysuria, fatigue, extremely painful, escalating menstrual cramping, very heavy menstrual periods. So really provide pain relief with analgesics if allowed to. So again, not at the advanced level, but these patients are going to require some kind of analgesic. to reduce that pain. However, I mean, if it's something that's light and it can be treated with Tylenol, they might be able to get that as well. Postpartum eclampsia. So after the baby is born, the mother is at risk for eclamptic for several weeks after birth. With this, seizures and hypertension in women who recently delivered a baby is a sign of postpartum eclampsia. Paramedic backup is required, as they require magnesium sulfate to actually stop seizures. Right. As far as sexual assault goes, most victims are women, men, and children are also victims as well. To provide compensation, provide compassion, and transport. So some patients will have multiple system trauma or a multiple system trauma event and need treatment for shock as well. All right. So kind of keep that in mind as you're assessing. So as far as patient assessment goes, obtain an accurate and detailed assessment. You need to be detailed. The OPQRSTI, what's been going on, how long has it been going on for, pain levels, radiation of pain, amount of bleeding, last menstrual cycle, if they're pregnant, we got to find out if they've been receiving prenatal care, where they kind of sit as far as like what trimester they're in, their due date. Is it you got to get the number of pregnancies versus number of live births, so paragravida, number of abortions. There's a lot of things that have to be gone into when you're part of your assessment, especially dealing with a pregnant female, where they kind of sit. All right. Have they ever had a C-section before as well? So take standard precautions. Gynecologic emergencies can involve large amounts of blood and bodily fluids contaminated with communicable diseases. Right. So look at the information you obtained to contribute your assessment of patient overall health, safety of the scene, MOI, NOI, looking at your general impression. Are they sick or not sick? ABPU, ABCDEs, right? If there's a significant blood loss, the patient may not demonstrate obvious signs of shock, but still may be hypovolemic, right? If they're bleeding from internally, there's no chance for us putting a tourniquet on, right? So we got to find a way or find out why they are bleeding and get them to the hospital so that can be stopped, okay? Nothing we're going to do in the field, but as advanced EMTs, cardiac monitoring's a must for these patients, right? At minimum a 4 lead, get a 12 lead if you have time to get it in. IV therapy, fluids. Keep the patient warm. In most cases, gynecologic emergencies are not life-threatening, but some of them are. History taking, chief complaint, right? Be sensitive to the patient's feelings, okay? They may have just had a spontaneous abortion, right? So ensure privacy and dignity are protected. Gynecologic emergencies can also be embarrassing for the patient as well. So many women will be extremely uncomfortable discussing their sexual histories, especially to a man, to a male provider, right? So get to the same level and have that conversation, all right? Be polite, calm, cool, collective, get the information you're looking for, right? When asking the patient about sensitive subjects, do so in a quiet manner away from other bystanders, all right? Not everybody in the world needs to know that this patient is sexually active, right? Especially if they're 14 years old. Ask only questions pertinent to your evaluation of her physical status, right? As well. So we talked about sample history, adding into the last menstrual period, associated symptoms, nature and location of pain, and how long it's been going on for. Ask about previous episodes of this pain as well. Has this happened before? And if it did, what was the cause of that? Did you see a physician for that before? When was the last time you went to a gynecologist to actually have to actually be checked out, right? So those things add in as well. Any recent surgeries, procedures, right? Any previous pregnancies? Ask about the presence of vaginal discharge. Inquire about the use of contraceptives. Right? Ask about missed or late periods. Determine regularity. Right? Anything different. Normally, if it lasts 7 days every time, this time it's lasted 25 days. That's a problem. Why? Why has it been going on? Have you talked to anybody about it? Right? Any kind of trauma, address it. Consider the possibility of pregnancy in any women of childbearing age, even if contraception has been used. Then we're going to get into our secondary assessment, which may be performed on scene or en route to the emergency department. Right? If you have the chance to get in the back of the ambulance and do your secondary assessment, then do so. At least it's more private, away from bystanders. Focus on the nature of illness and the patient's chief complaint, and always maintain privacy. Vital signs every 5 or 15 minutes, depending on stability. Tachycardic and respiratory changes may signal shock, remember. So tachypnea, tachycardia. Know the color and the amount of bleeding or discharge, okay? Let's see, use monitoring devices if available. We're AEMTs, working for services that have cardiac monitors. Pulse oximetry, you can run end-tidal if you need to. Cardiac monitoring, right? Auto BP cuffs. We have all these tools at our disposal at the advanced level. IV therapy, fluids, and then reassess. If you give fluids, reassess vital signs, and then document that in your reassessment that you saw a change in blood pressures. You saw a decrease in heart rate after fluids that were administered. You know, document all these different changes. En route, recheck your primary interventions, right? Ask them, because if their complaint may have resolved and have a different complaint now. Is anything different? Are there any changes on your reassessment, right? Then maintain the patient's privacy and modesty as much as you possibly can. So you want to make sure that we gain that patient's confidence by communicating appropriately and answering questions honestly. Don't make anything up. Sanitary pads on the external genitalia to absorb the blood, right? We never pack anything into the vagina. We always collect it from below, right? Establish at least one line, IV line, using a large bore IV catheter in a large vein. Administer 20 mL per kilogram bolus of isotonic crystalloid solution. If the patient is not demonstrating signs of shock, then place in a position of comfort based on a presentation, right? If they're pregnant, left lateral recumbent. Get that pressure off that vena cava and the aorta. Get that pressure off so we don't have supine hypotensive syndrome, right? So move the patient left side. That's why we turn on the left side, to get them off all the vital organs, right? We're going to treat any external lacerations, abrasions, and tears with sterile compresses. Remember that this could also be a sexual assault if there is any kind of lacerations or abrasions. So take note, document appropriately, right? No pictures. That's what law enforcement do. They handle all that kind of stuff with the specific kits that they have located in the hospitals, right? Please do not take your phone out of your pocket and start taking pictures of the vaginal area. Be prepared for a possible miscarriage as well. For the pelvic inflammatory disease, which will be lower abdominal pain, fever, vaginal discharge as well. The patient will generally walk doubled over and guarded the abdomen. So place his patient in a position of comfort. If it's laying on their side, then they lay on their side, whatever's comfortable for them. Then transport the patient to the appropriate facility. Every facility around here can handle gynecologic. They cannot handle labor and delivery, though. That's different. A rupture of ovarian cyst is a sudden onset of severe lower abdominal pain. So unilateral pain may radiate from the abdomen to the back, and then maybe some vaginal bleeding. Again, take note. All right, we already talked about the ectopic pregnancies, but if they do rupture, they usually show signs of hypovolemic shock, and bleeding may be very excessive, right? So monitor for impending shock using orthostatic vital signs. So can anybody here tell me what orthostatic vital signs are? What are orthostatics?
When you do well, what is the operation you do? You do it laying down, sitting, and standing.
Correct.
You take your
And we're
vitals,
looking
yeah.
for what? Yep. But vital
Looking
signs,
for-
looking for two specific vital signs.
Rapid changes in the vital signs.
But what two specifically are we looking for?
You're looking
Did
for
you-
a jump in either heart rate or the blood pressure. Oh, somebody just said it too.
Right. Yeah, we're looking for that change. So we do it laying down, sitting up, standing, 2-minute intervals, okay? So we want to see if anything has changed and they're hemodynamically stable, right? And if we have an instability, then we can start treating that with IV fluids, right? And cardiac monitoring. That's why it's so important for us to bring monitors into the house. Get our 4 leads, our 12 leads, whatever needs to be done, right? Vital signs, orthostatics, very, very important, right? If you start seeing signs of shock, we're going to see tachycardia, tachypnea, right? If you start seeing decompensated signs, late stages, right? We're going to start seeing the heart rate drop, blood pressure drop, hypotension, bradycardia. These are patients that are heading towards irreversible, right? So we got to fix that. We got to catch it on compensation. Oh, wrong button. Right. So vaginal bleeding, the patient may experience heavy vaginal bleeding. If so, we do not pack it, we collect it, okay? Take note of how much blood loss there actually was prior to transporting from the home. Remember that 3rd trimester bleeding is a serious emergency, placenta previa, abruptio placentae, right? So inquire about the onset of symptoms. How long has it been going on for, and is it very painful? What color is it? Dark, bright red, right? It's a difference. Always assume bleeding during the 1st or 2nd trimester might indicate a spontaneous abortion or miscarriage, right? So keep that in mind. Sexual assault can take many forms, but most common is rape. So whenever possible, a female rape victim should be given the option of being treated by a female provider. We don't always have that availability. We're not a full-time fire department that has female providers all the time, right? If the paramedic's a male and it requires paramedic intervention, unfortunately, the males have to go up back. If you can provide a female to ride with, who's an EMT, that's perfectly fine. But we cannot abandon or downgrade our care based upon the type of patient we're transporting, right? We still have to treat. But be professional, tact, kindness, sensitivity. They're all paramount importance with this, all right? All right, and to finish up, drugs used to facilitate rape. So if the drugs are still in the patient's system during your assessment, look for hypotension, bradycardia, difficulty breathing, seizures, coma, and death may occur, right? Date rape drugs. Sexual practices and vaginal foreign bodies, fisting being one of them. Organ rupture is possible. Peritonitis may result in insertion of live animals. They don't belong up there. All right. So again, treat your patients with dignity. Only inspect what you need to inspect. Only touch what you need to touch. Right? And treat your patients well. All right.